when, but I'm so happy to accept any invitation in the future. So you have seen with me that gum smile cases, they will be attractive cases, and we have seen the differential diagnosis. Then we discussed the open bite cases, skeletal open bite cases, the timing, the etiology, and we have different scenarios. Then we discussed the last two skeletal open bite cases. I'm sure that most of you have questions in your mind, and this is my mission, by the way, for the last 2 days, is to initiate questions. Why? Why? Can I do it? Yes, you can do it. You need to try. Do mistakes. You can fix them. We don't extract. We are not applying heavy forces. So even if you do mistakes, they are reversible. And you will learn from your mistakes. And keep on. Don't surrender to the negative, let's say, or toxic environment around you. Some of your colleagues, or by the way, Hong, Dr. Hong? Yeah, did you lose some of your friends after doing demon treatment? I mean, do you think when you start using demon system, are you going to have more friends, or you will lose some friends? You will lose some friends, because you will start arguing, or they will start arguing. This is not evidence-based, there is no scientific support, this is, let's say, marketing, it's not true, it's not happening, so this is okay. And this was, by the way, the environment around me. Once I started using the Raymond system, I was the first Raymond user in Jordan, by the way, and 80% from the sales of the dealer in Jordan at that time was only to my practice. But this is the normal thing with pioneers. So if you start something new and different, most of the people around you, they will give you toxic, negative, let's say, feedback. So forget about them and focus on what you are doing, and you will do magic. You will do it. Our final session, it will be about facial asymmetry. I like this section, by the way, because most of your patients, they will come with facial asymmetry. You will not see that in the early years of orthotreatment, I mean from 12, 16. And I hate to start early treatment, then I miss the asymmetry and the occlusal cavity. That's why, I'll do my best to push most of my cases till the age of 16. So in this section, I'll do my best to finish at 4. So we'll have almost 1 hour of questions, and this will be great. And as I have promised, I will leave a QR code for you. If you are interested, we can send you the slides that have written material, so you can memorize everything, especially placement and torque selection. And again, in facial asymmetry cases, I believe in the maxilla. Focus on the maxilla, mandible is a follower. That's why I call it maxillodontics. Mandible is innocent. It will follow what you do. And keep the idea of rotation. You are rotating the face. All of that started with that case. You have seen that case with me yesterday when we were talking about diagnosis and the components of attractive face, that triangular symmetry. All of that started with that case. While I was editing the photograph, where should I put that smiley photograph? Should I take the interpupillary line? Should I take the occlusal plane? Should I take the ears, the CBCT? What? Then I discovered the importance of the upper lip while smiling. So I want to share that with you and to see that this is happening. You have seen that with Ula, the open bite case with M-Smile later on. You have seen that with Maya and other cases. But for the coming 3 cases, you will like it more. So she was my patient when she was in 14. So when she was 14 years old, these 2 laterals, they were blocked palatal. And I was so lucky at that time. We didn't have, by the way, diameter braces. So I used conventional brackets with expander, great space for laterals, to put the laterals in their position. And I finished the treatment. Then she came back after 10 years. And this will happen for all of you. So your patients will come to you later on. That's why try not to start so early and try to address the trauma through, especially the things that are related to the face. And the most important thing in the face is the symmetry. So she came back after 10 years with edge-to-edge bite. This is class 3 with very obvious facial asymmetry problem. At the start, I thought that maybe the right side of her mandible is longer than the left side. So this was the first thinking. It's in the mandible, and her mandible is longer on the right side. That's why she had that occlusion. And the maxilla was adapting to the mandible. By the way, don't be surprised. This is one of the theory in orthodontics. You remember, part of the schools in orthodontics, they will base their diagnosis on the mandible, which is wrong, you know, it's the maxilla. So at that time, I thought that maybe the problem with the mandible, and I need to keep my hands away from her case. But I felt that no, I need to correct the maxilla, and let's see what will happen. These are the intraoral photos for Iman. So after 10 years, she maintained the retainers, I mean the fixed retainers. So in terms of teeth, her teeth, they are aligned, we don't have relapse. So it was the bone of their face. That's why I took CBCT, and this is a Planmeca CBCT with soft tissue. It has, so the tube will make around the face to make the bone scan, and while the tube is going back to the 0 position, it will make laser scanning for the face. So this is her face with the laser scanner. If you remove the soft tissue, and to see the underlying bone, you can see with me that her right orbit is bigger than the left one, and even the vertical height of the maxilla at the right side is longer than the left side. So the whole face is bigger on the right side. So it's a big discrepancy. And if you are a surgeon, let's say that I decided to refer this to the best maxillofacial surgeon in the world. Do you think he is going to touch the orbit, I mean the 43? Are they going to touch that part of the face? No. Even they will not touch this part of the bone, the leg bone, I mean the 42. So their work is below the nose, the 41 surgery. So me and the surgeons, we have the same team. And I believe in bone remodeling. So why not to do bone remodeling for her instead of the 41 surgery, and to see the response of the mandible. I was not sure what will happen, by the way. So it was a trial. So again, I will not take the interpupillary line as my reference, because if you take that line, you will exaggerate the problem. So her chin will be deviated more to the left. So I will not touch her case, and I will refer her case to the surgeon who will do the treatment based on that line, and you feel her face like this at the end, like zigzag. The smile, the upper lip, and the eyes. So the best thing to do is to keep the hands of the surgeon away from these cases. So I will not do that. I'll take the upper lip while smiling. And I did that. Then I said, what about the chin? I need to make something for the chin to see what will happen for my chin. So I decided maybe the best shape is symmetrical triangle, because the pointed part of the triangle will be the right final position of the chin. Then inside that triangle, I need to evaluate the occlusal cavities, so I can know where to put my force, anterior, posterior, in the middle. Then this is what I'm doing. I used to give a name for anything that I do. So I decided to call it triangular symmetry. This was more than 5 years ago. So I decided to treat her case using differential diagnosis on the right side. I'm expecting also tilting of her chin to the right. But again, all of that was theory at the beginning. I was not sure what would happen. And in other cases, you can change the position to the left, depending on your malprudence. So this was the theory behind what I'm doing. So this is the bond excision for her case. At that time, I used her case, in her case, lemon Q. But if you are going to use lemon ultima, this will be the torque. But don't forget, the low torque of lower incisor is flipped. So this is propline torque, because she has class 3, edge to edge. So you will have propline torque for the lower, retrocline torque for the upper, neutral torque for the canine. This should be the torque in such cases. She was not living in Jordan. She was doing her master's degree in UK. So the plan is to visit me in the Easter, the Christmas, so every 3 to 4 months. In her, one of her visits, I did everything. I did the pan-rebo, I inserted the tag on the right side between tooth number 5 and 6. I was not aware about the patterns of elastics, and she was improving. And someday when I was outside the country giving course in Dubai, the clinic called me. They told me that Iman, she traveled back to Jordan. So I was afraid. Is there any problem? They told me, no. She's happy with the result. And next week she will have hair engagement ceremony. And she wants to do debonding. I told them, why not to wait just 2 days? Doctor, no, she insisted to remove the brace. Today. So I told them, okay, do the debonding, but please take photographs. So they took photographs after debonding. These photographs were done by my team, not by me. And if you notice, still, the lower midline shifted to the left, but she is happy. I would love to do overcorrection in such cases. She left the practice. I didn't know what her face looks like. But you'll see that later on. And they couldn't remove that cut. I asked them to give her upper essex retainer to maintain the amount of art development, and she left the country. And we heard that she moved from UK to Germany to do PhD degree. And we lost the contact for that patient. So again, this is the right side of the bind, and I added one tab. And if you check, I put crumble hoop there. So I asked Iman to change that power chain every week. So we did good amount of differential reduction on the right side. That elastic should be posterior triangle, not anterior triangle. And this is the right buckle view done by the team. And she left that tag there. So again, this is Iman in her consultation visit. And this is her case after less than 1 year with that tag on the right side. And we lost the contact with Iman for 8 years. So this was in 2015, and she came back in 2023. If she is your patient, and she called your practice after 8 years, are you happy? You don't know what will happen. But by the way, she called the practice not for her bite, because she wants to take consultation for her husband. They got married and they moved from Germany to Kenya in Africa. And they traveled from Kenya to Jordan for consultation for her husband, Tanner. And Tanner, he has the same asymmetry. And she wants me to correct that asymmetry for Tanner. So let's check. But once I have Tanner, I ask my team, deal with Tanner, bring Iman. I need to see Iman. And please, Iman, the people all over the world, they are waiting your case. So let me take some photos for you, Iman. So I took intraoral photos. After 8 years from that date, no retainers at all. I don't know what will happen with her occlusion. But this is her bite after 8 years. So this is her bite in 2015, and this is her bite after 8 years. What do you see? In terms of intercuspation and midline. Even it's better. So things are improving. And this is what I like with impaction. Because every time when she eats, she is stabilizing your outcome if you have the right, let's say, swallowing. So once I saw that bite, again, the tab is there after 8 years. And the fixed retainers, they are intact. We need some cleaning already. I told her, Iman, let me do some overcorrection, please. So I added active retainers with elastics. So I will ask Iman to keep these retainers only sleep time. I want to continue the induction, the right side. I want to do overcorrection of the midline and the lower arch. So hopefully she is using them. I'm not sure what's happening. And this is her letter staff at the consultation session. This is her letter staff just before engagement. And this is her letter staff after 8 years. So the case is stable. So yes, maxillodontics is the right term for such cases. And let's see her face and smile. This is her at the start of the treatment in the panel session. And this photograph was taken by my team just before the engagement. Then they have her after 3 years just to take another spinal photograph. By the way, from 2015 to 2017, no retainers. I need removal retainers without retention. But you can see with me that her case is stable. And now we have the chance to take another spinal photograph after 8 years. Always compare that with the start point. Deviated chin and lip to the left. I thought that it was in the mandible. I used only one tag. It was incomplete treatment without repairs. So differential impaction for the maxilla is effective for the face symmetry. So yes, upper lip while smiling is the right reference if you want to restore the symmetry of the face. I would love if I can do overcorrection with retention, but we didn't complete the treatment. And at that time, she didn't use any retainers with elastics. So yes, if you do differential impaction on the right or left side in the maxilla, mandible will follow. So again, if you do differential impaction, the mandible will follow. So it's about the maxillary ridge. And I decided to apply that to all of my patients. So this was the lady care Iman, and she is so happy. She said that she avoided surgery, and she is thankful for what we have done to her. So I decided to apply that even for plastic cases like Massa. And I need your genius look about the face of Massa. We need to evaluate the face now. Do you think she has symmetrical or asymmetrical face? Of course, asymmetrical face. So which part is bigger? The right side or the left side? Right or left? What's the meaning of right in Vietnamese language? Right. Right or left? Right. But the canting is opposite to the asymmetry. So this means what? Always if you see the teeth, they are not along the face. This is because of two reasons. Maybe she had ortho treatment, and that ortho treatment affected the normal development of the malocclusion, or maybe the tongue played a role, and it's because of the tongue. So she has atypical swallowing to the right. That tongue made that open bite with reverse speed, with the reverse smile arc. So the tongue was behind the reverse canting. So the canting on the left, but her right side of the face is bigger. She has true skeletal class 3, but because of the tongue thrust, she has bimax. But she is in class 3. And if you check the intraoral photos for NASA, you will see severe midline shifting, and she has unilateral or right open bite on the right side because of the tongue thrust, and she is in a class 3 foliolet on the right side. By the way, Masa, she was on the dental chair in one of the dental offices in Jordan, Amman, and she has the referral letter from her old orthodontist asking that dentist to do what? She had the referral of her old orthodontist to the dentist to do extraction of 8 teeth. Wisdom teeth, and to prepare her for orthodontic surgery. So he will extract the upper 4 and lower 5 to express the class 3. And that dentist was about to give her anesthesia to extract the teeth. Then that dentist said that there is something wrong, so he told the mother, why not to take a second opinion with Badr? So she came to me, and they were convinced that she would need surgery, but why not to take second opinion just to show that to the dentist? When they came to me and I told them, yes, I can take care without surgery, they became angry. Everybody told them that they will need surgery, but we are not believing you. Better. That's why I use insignia in her case. So I take their approval about that occlusion. We extracted the wisdom teeth and we started the treatment. You need to control the tongue. So the first thing to do is to put tongue tamers. So I bonded 2 tongue tamers and I added another 2 tongue tamers later on. But if this is your case using Demon Ultima, I need your help now. Let's have this thing. If this is your Ultima case, what will be the torque for the upper incisors? Retrocline torque. What will be the torque for lower incisors? She has a class 3. What will be the torque for lower incisors? Brookline. So this will be the torque for that case if you are going to deal with that case using Demon Ultima. You see the amount of open bind and the tongue therapy. So we started to modify her swallowing. I'm applying asymmetrical class 3 mechanics. All of the class 3 cases you need more force on the affected side. And we are going to create space medial to lower right canine. And we are going to do asymmetrical retraction to the right. So things are moving. Now it's time to evaluate the face. So this is her face after that session. You remember, the canting was on the left. So always you need to create the true malocclusion. So this is the true mask. So the canting is following the face asymmetry. That, let's say, masked malocclusion was because of the tongue. We'll apply the same principle. I want to correct her canting, so I need 1 tag only on the right side. So I added 1 tag on the right side between tooth number 5 and 6. To do differential reduction, this is the reduction. I'm guiding her mandible to fit in class 1. And now we corrected the midline. She finished the school. She has to travel to UK to study fine art. And I have learned from Iman case. So I refused to do full debonding. I told her I'm going to debond the upper arch. We'll continue using elastics. I moved the tag from posterior segment to be distal to upper canine. And I will ask her to apply elastics to do overcorrection. So again, this is the case on the right side. Conscious swallowing exercise, tongue tamers. So we close the open bite just by doing conscious swallowing exercise and tongue tamers. Then we added the tag for the face to correct the canting and to correct the face asymmetry. Posterior triangular class 3. Shift the canting. I asked her to put that elastic only at sleep time. Nothing special in the upper arch, even we didn't use, these are the traces of the IPR. I didn't need tongue tamers on the upper arch, only in the lower arch. So in the lower arch, These are my deprogramers for conscious swallowing exercise. And for the lower arch, I added extra 2 current cables on the right side because she is traveling. I want to make sure that I stop the lateral tangent. So this is massa before, and this is massa after. So intraorally we are happy. The overjet was corrected. The class 3 was corrected. And always, if you have atypical swallowing, you are not happy about the muscle strain. You can see that in her face. You see the texture of the lips and the mentalis muscle is abnormal because abnormal tongue position. Once you correct the tongue, this will what will happen to the face muscles. They will be relaxed, balanced. The same with the frontal view. Her chin is deviated to the left, and her mouth is tilted. But this is her mouth and this is her chin after differential impaction. So we restored the symmetry of the face. And for the smile, you remember, we have face asymmetry and canting, and this is her smile at the end of the treatment. You feel that she has now symmetrical face. Even her chin with that black dot almost in the long edges of the face. New face. One tag. Remember, she was about to be prepared for orthographic surgery. So one tag with persistent propagation can do that. And if you follow the movie, you can see the amount of correction like Iman case. So it's working, and it's effective, and it's beautiful. So that's why it's a standard in my practice. So please, take the upper lip while smiling as your reference in all of your cases. The same problem. She was about to have admission to do orthographic surgery. They told her, by the way, her brother is one of the best or good dentists in Georgia, but she took consultation and they told her, look, Ran, your case is skeletal one, you have gummy smile, and you need to do report one surgery and a liver surgery. And she was about to accept that. She has convex profile, she is not happy about her face, and you can see the amount of canting. Intraorally, we don't have bite. Even she had all the extraction on the upper right side. The space is closed, but for me, symmetry is more important. So I will restore symmetry. I will open the space for future implant. These are the intraoral photos. Sorry, this is the panoramic X-ray for Ren. And again, all of them, they are retreated. Most of my cases are retreated because they will lose the guidance. They hate invasive procedures, so they will come to you. What should be done? Even for the upper right ear. I know that we extracted, she has extracted premolar, but I will extract the 4/8. So we extracted the 4/8, and I'm going to apply the same principle. So I needed to do differential impaction on the left side, but because she has gum smile, one tab is not enough. I'm going to use 4 tabs. Yeah, because I'm going to intrude even on the right side. So this is the day of bonding. And you know, my torque selection is a learning curve. All of that is wrong. All of that is wrong. What should be the torque? This should be the torque. And I changed that during the treatment. You will see that torque later on after the bad video. So this is the day of bonding. with the wrong torque, I'm creating space now on the right side for a future implant. Then after the fourth wire, you need to do the panorama. So this is her smiling photograph in the panorama. So she is showing more canting. So this is the panorama. I did the repositioning for the upper left central, upper right lateral, and she was in a rush, so I started the impaction, even in flexible wires, but for a short period of time. Then later on, I put my stencil wires, and the force on the left side is more than the right side. You don't see the posterior tag here, because I put my tag on the right side, distal to 7. Distal to 7. Still we are doing impaction, more on the left side, and I'm controlling her tongue thrust, because she had anterior tongue thrust habit. I'm guiding her mandible to bite in class 1. And this is the session where I did repositioning for 12 brackets. I did repositioning for 12 brackets. I changed the torque for the whole anterior segment of the lower arch. So I changed them to be retrocline torque and neutral and canine. The same for the upper. So I did the repositioning for 12 brackets. Now you like her bite after changing the torque. So the bite now is settled. Before that, I couldn't settle her bite. So the torque selection will help you to settle the bite. Again, we are doing differential impaction more on the left side. And this is her final intraoral photograph. You remember we started with black triangles between the lower incisors, but now we don't have any black triangles. I left that tag for retention. Let's see here, right buccal view. We extracted the upper right 8 because I want to utilize tooth number 6 and 7 to create implant at the side of the extracted tooth was 4. But I will not put the implant medial. Always when I need to create space, I'll do my best to put that space more distant. So I will create the space between 5 and 6, not canine and 5. Because I want to have my implant in the posterior segment of my arch. It's not aesthetic to have it distant to the canine. We are creating space. We started the impaction, creating more space, and this is my tag on the upper right side. It is distant to 7. It will do both, distalization and impaction. More distalization and impaction. More. By the way, she was among the patients who are taking biotin. So she had very slow teeth movement. Then we asked her to stop biotin. This is the second binary position where I changed the torque for 10 brackets and I did the repositioning for 2 brackets. So the total was 12 brackets in terms of repositioning. I'm guiding here occluded in class 1 and we finish here occluded in class 1. For the 7th, they will settle with the showing exercise. So now she's in class 1. She was in class 2. The same on the left side, she was in class 2 occlusion. The impaction was on the left side more. We are controlling the tongue position. This is the repositioning for her wrong bracket torques. We are doing finishing elastics. They are 1-on-4 heavy. And this is her beautiful bite in class 1. This was just after the bonding, so the bike will settle. For me, I need to restore the symmetry of the upper arch. That's why I will create the space between 5 and 6, not 5 and T9. This is my tag. To do the sterilization and impaction. So if you have asymmetrical extraction in the upper arch, you need to restore symmetry. Don't keep the space closed. Symmetry is more important than the number of the teeth or the number of implants. Hair site is ready for implant later on. Nothing special for the lower arch except the tongue tremors. So these are the intraoral photos for run before and after. So you can see the change in hair occlusion. And this is hair panoramic X-ray, and the space now is ready for a future implant. These are the photos for the overjet. By the way, this is so important. I need from you to follow the chin now. This is before the treatment, before impaction, and this is after. Follow the chin. Follow the chin. What do you see? We are affecting the face, the whole face. We are putting her chin in more forward position, more chin projection. Again, if you follow the extraoral graph. So we created a chin. It was there, but the whole thing was downward, backward rotated. So if you impact the maxilla, the mandible will have anti-clockwise rotation. And this is effective. But her lipstick at the beginning of the treatment masked the problem, no? But we gave her a chin. So this is for the profile. What about the smile? You remember she came with that canting? And this is her chin. So it was severe asymmetry. And this is her smile at the end of the treatment. So all of that because of differential impaction on the wrist side. So you can deal with face asymmetries and you can restore the beauty of the face. I didn't change the symmetry of the eyes. Still, they are looking asymmetrical, but all of you are focusing on the smile. Because yes, the upper lip is the right reference for the smile. What else? Again, subconscious brain. Here, subconscious brain is hiding her gum smile. So the upper lip is turning down. So this is not her true smile. She's hiding her asymmetry and gum smile. Now, she's using the elevator muscles for smiling. We are planning to do whitening before doing the implant. So we restored at the midline. Coincidence, she has little smile arc, she has gorgeous smile, and she's so happy. She's so happy. Wow. That slide, or this slide, is slide number 1760. So, thank you to you, my God. The next slide is the most important slide. Maybe Demon Ultima was behind our gathering, but it's not the bracket. Maybe that bracket will give you the right switch to have the right turning point in your life. So use it. Use it to be the best version of yourself. Number two, you need to dream to be one of the best orthodontists, not in your city, not in Vietnam, maybe in the region. So always keep the spirit to be an outstanding orthodontist. Number three, you need to be artist. So if there's any workshop or composites, please attend. Do the build-ups, do the hard tissue, do IPR, do soft tissue contouring. Number four, take care of the small details. But you will not be able to do that without taking very, very, very good records. You know the effort behind all the pictures that I have been presenting for the last 2 days. We are talking about years of work. We are talking about maybe millions of photographs. I used to do the editing myself. I used to take the intraoral photographs myself. So you need to have the right management for your time to have the quality of your records. Number five, remember, face, smile, teeth. The three levels of aesthetics. Macro, the face, mini, the smile, micro, the teeth. Number six, select your patient. And sometimes the parents of the patient. So don't want any case. Try to select or pick your patients. If they are not doing their job in terms of oral hygiene, if they are not in the right timing, take care. Don't put yourself with the troubles with uncooperative patients. And finally, enjoy what you are doing by doing quality orthodontics. Quality orthodontics means you are doing something that should be reflected on the life or the quality of the life of your patients. You are changing their life, their dreams, everything. And the four pillars for quality orthodontics, it should be simple, safe, efficient, and to keep the smile, number four, as top priority. And I have been presenting safe, simple orthodontics for you, even with the challenging malocclusion. After this event, part of you will go home, part of you will travel, maybe some of us will take the airplane. So I'm not sure when will be our next meeting. That's why it's time to talk about the future plans. So one of the things that I'm doing in my practice